Today we're going to be talking about pediatric lung diseases. This is part one of a two-part lecture where we'll be focusing on respiratory distress in the neonate and infant. Your primary reading is really this lecture PowerPoint and the narrated presentation. I've included some recommended reading if you have the additional time and interest. As you should know, my test questions come directly from my objectives. I want to remind you that kids are not just little adults. They are anatomically and physiologically different than adults, just like Dr. Katz says there. They have a more compliant chest wall. They've got a greater reliance on their diaphragm over their intercostal muscles in comparison to adults. They have smaller and fewer alveoli and smaller and more collapsible intrathoracic airways. And then it's important to remember that birth is a traumatic process. It's prone to producing somatic dysfunction in both the mother as well as the newborn. What's the definition of respiratory distress? Impaired air exchange that leads to decreased ventilation and oxygenation. The patient increases their breathing effort in order to compensate. This can occur for a variety of reasons. Those reasons could center around a problem within the pulmonary system, the cardiac system, could be metabolic, infectious, or renal in cause, could come from the gastroenterologic system or neurologic. Respiratory distress is bad because it's a sign that there's a pathologic process going on. Patients, usually neonates, can use up their pulmonary reserve. They can essentially tire out and not have the energy to continue breathing anymore. This may eventually develop into respiratory failure. The signs and symptoms of respiratory distress are things that I've talked about in prior lectures, such as tachypnea. Remember that in newborns, they can breathe up to 60 breaths per minute, so tachypnea is quite quick for them. Presence of retractions, which could be intercostal, substernal, supraclavicular. They could have nasal flaring. They could be grunting with every single breath, like a tennis player. They may be diaphoretic. They may be lethargic. Their skin may be pale or cyanotic, showing that they're not getting enough oxygen. And they could have acute thoracic tissue texture changes. Our basic evaluation for respiratory distress includes a chest x-ray. That's usually the first step after we clarify the history and do a thorough physical exam on them. Remember, there's a lead time for all studies, so we want to order it early if it may take a while in order to get it. Right? So if it might take a while for the infant to actually get to the imaging suite or for the imaging people to be able to transport a portable x-ray to where we are. ABG, we consider this regardless of whether or not we're going to get a chest x-ray. This really gives us clues to impending respiratory failure. It's more useful for triage purposes than it is for diagnosis. Will I need to send this person up to the ICU, or will we be able to manage them on a general pediatric floor? A CBC with diff and a blood culture can be helpful if we think that there may be infection. And then, based on our clinical suspicion and what we think may be going on with the infant, we may order advanced imaging, like a CT scan, a bedside ultrasound, an echocardiogram. The management of respiratory distress is generally supportive. We're going to practice basic life support, so A, B's, and C's, airway, breathing, and circulation. We're going to provide oxygen and respiratory support, like mechanical ventilation, as needed. We're going to offer fluid and nutritional support. Remember the importance of fluids, especially if somebody's tachypnic. They're going to become more dehydrated more quickly than somebody who's not tachypnic, because essentially they have all of these excessive losses of fluid from their fast breathing. And then OMT, things like rib raising, lymphatics, and thoracic pump, anything that we can really do to help support both the mechanics as well as the viscerosomatics of our patient. And then clearly, we want to try to figure out what the underlying condition is that's causing the respiratory distress, and then treat that as specifically and urgently as possible. What are some causes of respiratory distress in the newborn? We'll be talking about respiratory distress syndrome, transient tachypnea of the newborn, meconium aspiration syndrome. I have already spoken to you about congenital heart disease and pneumonia. So causes. All of those can present similarly. So the circumstances of the newborn's birth really provide important clues to the diagnosis. That's what's going to clue you in, whether you're answering a test question or whether you're seeing a patient and figuring out what the best treatment plan for them is. So let's start with one of the most commons. It's actually the most common respiratory disorder in newborns, transient tachypnea of the newborn. One quick definition, newborn means an infant that's younger than 28 days. So within their first 4 weeks of life, they're considered a newborn. After that, under 12 months of age, they're considered an infant. Transient tachypnea of the newborn, or TTN, it occurs because of delayed resorption of fetal lung fluid. Usually occurs in full-term, otherwise healthy newborns. And there is an association with newborns that are delivered via cesarean section and without labor, meaning mom may have had a prior C-section, and so this is just her second delivery. She knows she's going to deliver by C-section, so she doesn't labor at all. The process of labor helps to squeeze some of that fluid out of the fetuses and out of the newborn's lungs. Typically, these infants are tachypnic immediately after birth, and they have some mild respiratory distress. Their chest x-ray shows hyperinflation with clear lung parenchyma, except for possible perihilar linear densities and fluid in the fissures, but there's no consolidations, nothing that looks like pneumonia. And then typically, even on their own, these infants stabilize and improve over 12 to 48 hours. If they don't, then we need to think about what other diagnoses could be going on. The key word here is it's transient. It just happens immediately after birth in those full-term kids, and then it goes away. The treatment is supportive care, mainly oxygen if they need it, and observation. Very, very, very rarely do they require advanced support like ventilation. Here we can see x-rays of a TTN. So the first one shows bilateral pulmonary edema. So we can see there's a little bit of fluid in that right horizontal fissure, just a tiny little line where that arrow is pointing to. And on the repeat one, 24 hours later, that edema is gone. The lungs look clear. Don't forget about the thymic shadow, right? If you're thinking that that child's heart looks a little abnormal, you're probably seeing some of the thymus. Let's move on to another cause of respiratory distress in the neonate, meconium aspiration syndrome. Meconium is fetal feces. So it's the fecal material that a fetus produces when they're in utero. If meconium is in amniotic fluid, that occurs in about 15 to 20% of all pregnancies, and of those, about 15% go on to develop meconium aspiration syndrome. Meconium is sterile itself, but it's irritating. Basically causes like a chemical pneumonitis if it gets into the child's lungs. It can be obstructive, so meconium is really sticky and really thick, so it could clog up the airways, and it could make the child more prone to infection. Obstruction of large and small airways of the aspirated material are what cause meconium aspiration syndrome. And these kids are usually full-term or post-term infants, and they're born with a moderate to thick meconium in the amniotic fluid. If you haven't attended a lot of births, or you haven't attended a birth with meconium in the amniotic fluid, then you may not know that typically the amniotic fluid is clear, maybe a little bit yellow tinged. If there is meconium in that fluid, it is dark and green and thick, looks a little bit gross. It's really hard to miss. The symptoms of meconium aspiration syndrome are similar to transient tachypnea of the newborn. but they're more severe. You can see, if you look closely at this picture of this baby, some of that kind of sticky, cheesy stuff that is on him is a little bit green tinged. And that tells me that he was born probably post dates, right? Meaning he went beyond the typical 40 weeks. Those are the infants that are more likely to have meconium. Yeah, and so we can see that he has a little bit of that staining on his skin and on that material. The symptoms develop immediately after birth, like transient tachypnea of the newborn. Some may have a little bit of a delay with the symptoms. And like I said, it tends to be more severe respiratory distress. Remember, with TTN, they're just having mild respiratory distress. The chest x-ray is going to vary between hyperinflation, like we see with TTN, to significant heterogeneous lung disease with hyperinflated areas and linear rope-like patchy infiltrates. The treatment is supportive, often including supplemental oxygen if the child is either showing signs of that moderate respiratory distress or if they're hypoxic. They typically improve after several hours to days. And at delivery, like I said, you can't miss when there's meconium involved. So at delivery, you may consider intubation and then suctioning of those airways prior to stimulating the infant, right? So as soon as a newborn is born, the first thing that we do is we start rubbing them and drying them off. So we're stimulating them, right, to kind of kick them into gear to being in this outside world. If we were to start stimulating a newborn who has meconium in their mouth, they may all of a sudden inhale and aspirate that meconium. So we may want to suction that stuff out of their mouth before they have that opportunity to aspirate it. Here we can see x-rays of meconium aspiration syndrome. So once again, we see that hyperinflation, which means that the diaphragms are really flattened. I would expect those diaphragms to be a little bit more domed in a normal infant. We can see on that top image those coarse opacities, so all throughout the lung fields, there's some coarse opacities. I can see a little bit of linear streaking in those. And then do you see on the bottom image, so right along here, so right along the left side of that image, there's actually a pneumothorax. So you can see an area where it's nice and dark. If you can't see that, come and find me and we'll talk about it and we'll review a little bit of x-ray reading for you. Spontaneous pneumothorax does actually happen in infants that have meconium aspiration syndrome about 20% of the time. This is the outline for management of deliveries with meconium-stained amniotic fluid. So first we note that there's meconium-stained amniotic fluid. Then we're going to do minimal stimulation and keep the newborn's head down to prevent breathing in their meconium. The OB-GYN team should hand the infant to the neonatal, to the pediatricians. If the infant is vigorous, then we're going to treat them as normal. If they're not vigorous, we're going to intubate and start sucking out their airways, try to get rid of any meconium that may be in there. The next topic we're going to talk about is respiratory distress syndrome. So we talked about transient tachypnea of the newborn, meconium aspiration syndrome, and now we're moving on to respiratory distress syndrome, or RDS. This is also known as hyaline membrane disease. This occurs in premature infants, so those infants that are born under 34 weeks of gestational age. It can occur as well to full-term infants of diabetic mothers. The incidence and severity of respiratory distress syndrome increases with decreasing gestational age, so you're higher at risk of developing respiratory distress syndrome if you're born more premature. The pathophysiology of this is immature alveolar cells. So the alveolar cells should produce surfactant, and surfactant helps to keep the alveoli nice and open. If an infant is born too premature, they don't have enough surfactant, and so their alveolar cells are collapsed, or they have atelectasis. That proceeds to lung tissue ischemia and sloughing of tissue and edema, and then hyaline membrane formation. So we suspect RDS when respiratory distress occurs right after the birth in a premature neonate. Remember that with transient tachypnea of the newborn, we're looking at full-term infants, typically those who are born via C-section without mother going into labor at all. For meconium aspiration syndrome, we're also looking at full-term newborns. Really, we're looking at post-term newborns, and clearly we're looking at the ones who have had meconium in the amniotic fluid. With respiratory distress syndrome, these are premature neonates. And unlike TTN and MAS, RDS, the respiratory distress actually worsens over the first few hours of life. If they have prolonged disease, if they don't get surfactant right away and their alveoli cannot increase, then that can progress to chronic lung disease. That's something that we'll talk about in part 2 of this lecture series. Their chest x-ray shows decreased lung inflation. Remember with the other two, we actually saw hyperinflation. And they have diffuse symmetrical reticulogranular or ground glass appearance of the lung fields with air bronchograms. And I'll show you an image of what that looks like. How do we prevent it? If we can give prenatal administration of systemic corticosteroids to the mother when she's between 24 to 34 weeks of gestation, that reduces the risk of RDS. We don't want to give all pregnant women steroids if they don't need it, so we only give it to those women when we know there's a high risk of preterm delivery. We know that these infants may need advanced respiratory support, so they may either need a CPAP or they may need to be intubated and ventilated. Surfactant is the treatment of choice, and the way that we give surfactant is we actually intubate the newborn right at the time of delivery, and then we squirt surfactant down the intubation tube directly into their lungs. We can consider postnatal steroid treatment of the infant, but it's associated with developmental cerebral palsy, so that's not necessarily something that we give. And otherwise, we're providing supportive care, right? Especially with oxygen as needed. Here's the x-ray of RDS. So we can see these lungs are not hyperinflated. It's actually difficult for me to see exactly where these diaphragms come up. And if you look closely at that image, you can see some air bronchograms, which means kind of the outline of the pulmonary tree. And they have that ground glass appearance throughout all of the lung fields. This is a chart that's comparing all three of those disorders. So transient tachypnea of the newborn, meconium aspiration syndrome, and respiratory distress syndrome. So you can use this, read up on it, make sure that you know the difference, and you'll be able to identify them on test questions. Some other causes of respiratory distress in the neonate include pneumonia, which is something we've talked about a little bit. The clinical factors to think about for pneumonia is prolonged rupture of membranes. So if mom's bag of fluids broke or her membranes ruptured for longer than 16 or 18 hours, that would put the infant at risk of getting any neonatal infection, including pneumonia. If mom had an infection at the time of delivery, or if the infant was premature. On chest x-ray, we may be able to see a specific infiltrate consolidation, or the lungs may look hazy. It can actually look like RDS. Those infants typically have some temperature instability, so they may be febrile or hypothermic, which may clue us into the fact that there's an infectious etiology. And it may happen in term infants and not premature infants, which is what we expect for RDS. Pneumothorax. So the clinical factors is an infant's doing fine and then they have a sudden deterioration. Often it happens while they're on the ventilator. So remember, of those that we talked about, meconium aspiration syndrome can be associated with pneumothorax. On chest x-ray, we can actually see that collapsed lung, kind of that black outline on the outside of the lungs, free air in that hemithorax. And then cyanotic congenital heart disease can also cause respiratory distress. Typically, you'll be able to hear the associated murmur. These infants may have persistent hypoxia even once you have oxygen on them, and they may be cyanotic even without respiratory distress. The chest x-ray may show cardiomegaly. They may have hypoperfused lungs, depending on what the underlying etiology is behind their congenital heart disease. And oftentimes the chest x-ray in these infants looks fairly normal, aside from some cardiomegaly. In summary, respiratory distress in the newborn. Differences in the neonatal pulmonary physiology predispose them to respiratory complications. We use clinical factors to help determine management. Were they born premature? Were they born at term? Were they born post-dates? And was there any meconium in their fluid? The things that are most common are transient tachypnea of the newborn, meconium aspiration syndrome, and respiratory distress syndrome. They're among the possible causes for respiratory distress in the neonate. I've included some pictures across the top for you to look at so that you can compare the different x-rays of each of those. We're now going to move on to sudden infant death syndrome and BRUI. Sudden infant death syndrome. The definition is the sudden death of an infant, which is a child less than 1 year of age, that remains unexplained after review of the clinical history, complete autopsy, including a skeletal survey, metabolic and infectious disease assessment, toxicology investigation, and examination of the death scene. This is a diagnosis of exclusion. We are ruling out that nothing else happened. It is just the sudden death that cannot otherwise be explained. The epidemiology. We've seen a recent decline in SIDS deaths. Part of that is largely attributed to the Back to Sleep campaign, putting newborns and infants on their backs to go to sleep. It remains the #1 cause of infant death outside of the neonatal period. Remember that a neonate or a newborn is the first 28 days of life. 90% occur before 6 months of age, and this peaks between 2 to 4 months of age. And the exact etiology is unknown, but the most recent studies show this overlapping trilogy of an infant within their critical developmental period, so that's under the first year of life, who's considered vulnerable by intrinsic factors. There seems to be a genetic component behind the infants who die of SIDS. And extrinsic factors, such as their sleep positioning, being put to sleep on their side or on their stomachs, the type of bedding that they have, smoking, those type of things. So there seems to be an overlap of all three of these. The risk factors, the biggest one is placing a baby on their stomach or prone for sleeping or on their side. Putting an infant to sleep on a soft surface. The mattresses that we use in infant cribs should be firm. Co-sleeping, so sharing a bed with a baby. Parental smoking is one of the biggest risk factors that we've seen. Lack of adequate prenatal care, young parental age, and prematurity and/or low birth weight of the infant. You'll see that I included in here a public awareness campaign on SIDS that outlines some of the risk factors and some of the preventing factors, which we'll talk about. The differential diagnosis includes non-accidental trauma or child abuse, fatty acid oxidation disorders, like a metabolic disorder prone to hypoglycemia during fasting, long QT syndrome, right? So an arrhythmia that might have led to it. And then there's many others. That's part of the reason why an autopsy is so important in these cases, so we can really see if we can outline a cause. When we're comparing sudden infant death syndrome to non-accidental trauma, it's really difficult to distinguish, next to impossible to distinguish, deliberate asphyxia, meaning somebody suffocated the newborn or infant, from SIDS on autopsy. Red flags for non-accidental trauma, and you will get more teaching on this by me in your second year, is previous recurrent cyanosis, apnea, or BRUI while in the care of the same person, an age of death older than 6 months, right? So we tend to see SIDS much more commonly younger than 6 months. Previous unexpected or unexplained deaths of one or more siblings. Simultaneous or nearly simultaneous death of twins. That is very rare to happen in an accidental setting or a sudden infant death syndrome. And previous death of infants under the care of the same unrelated person. How do we prevent it? The Back to Sleep campaign has been the primary mainstay of us preventing sudden infant death syndrome. We have seen a great decrease in the SIDS rate with an increase in supine sleeping position. It's important that there's no wedges or other sleep supports in the crib. I want to point out that in that picture that I have, that is really just showing you what an apnea monitor is. Apnea monitors are bad, so I do not want you to think that apnea monitors are a good thing because they're pictured in here. But there are other bad things in that picture, such as the fact that there's that crib bumper. That's that soft kind of bedding-like thing that's put up on the crib slats to prevent an infant from sticking their arms through the slats or hitting up against the slats of the crib. That's actually really dangerous, and we do see quite a few infants who die by suffocation when they have those bed bumpers. The other thing that is bad in that crib is the loose blanket that could get wrapped up over the kid's head, and a stuffed animal. So not only is the apnea monitor that's in there bad, but so many other things in that picture are bad. Infants should really be sleeping on a firm crib mattress with pretty much nothing else, right? They can be in their nice, comfortable, warm pajamas, but no other things in the crib with them. So we should remove loose or thick bedding. Crib is the preferred sleeping environment. So the American Academy of Pediatrics has just recently updated their recommendations, and they recommend that newborns and infants sleep in the same room as the parents, but sleep in their own space, because we see way too many newborns and infants die in co-sleeping environments. We definitely want to counsel the family on smoking cessation, because we do see an increased incidence of SIDS in households where there's smokers, and avoid overheating the infant. We also see that more incidences of SIDS when an infant or a newborn is overly swaddled or has too thick of pajamas on. There are home apnea monitors available. They have not been shown to decrease the risk of sudden infant death syndrome. They have been shown to increase the anxiety of parents. And I say that a little bit tongue-in-cheek, but it's very true. The apnea monitors will suddenly go off and the parents will jump out and they'll freak out, and the kid is breathing absolutely fine, and it's just that the monitor isn't connected appropriately to the child. So it's not something that has been found to be helpful in really any setting. Here's another public safety campaign. Charlie's Kids Foundation. You can imagine that Charlie was a child who died of sudden infant death syndrome, and it's outlining the do's and don'ts for safe sleep. You can see that sleeping with a pacifier is something that has been shown to decrease the incidence of sudden infant death syndrome, but we don't want to hang the pacifier around the baby's neck on a cord that could strangle them. We're going to move on from sudden infant death syndrome to BRUIs. BRUI stands for Brief Resolved Unexplained Event. This is defined as an episode that is frightening to the observer. It's characterized by some combination of apnea, color change, marked change in muscle tone, choking, or gagging. And in some cases, the observer fears that the infant has died. They may have initiated CPR, they may have started some back blows, they may have started to otherwise stimulate the infant because they're worried about it. BRUI is not a specific diagnosis. It doesn't tell us what happened. It just tells us that this event happened. We used to call this an ALTI, an apparent life-threatening event, but now it's called a BRUI, a brief resolved unexplained event. And I think the word resolved is really the component that was missing in the word ALTI. So BRUI, it's brief, typically lasts less than 1 minute. Usually it's really 20 to 30 seconds. It is resolved. The child returned to their baseline state of health after the event. Their vital signs are normal. It's unexplained. We don't know exactly what caused it. And then it includes either some cyanosis, some decreased or irregular breathing, some changes in tone, or altered responsiveness. More definitions. Apnea. Apnea is defined as the absence of spontaneous ventilation for 20 seconds, or a shorter duration if it's associated with cyanosis or bradycardia. We further categorize apnea as central, meaning there's no respiratory effort. There's absolutely no internal drive to breathe. Obstructive, meaning there's a sustained effort without airflow. So basically trying to breathe through a plugged up straw. Or mixed, a combination of central and obstructive apnea. And then there's periodic breathing. And this is something that all infants do. It is a normal pattern of infant breathing that's defined by 3 or more periods of breath holding, lasting at least 3 seconds, and separated by less than 20 seconds of breathing, right? So they don't actually become apneic when they're periodic breathing, but infants will breathe, and excuse me for doing some deep breathing into the microphone, but I want you to be able to hear it. They will breathe in a pattern like this. So it'll be this periodic breathing that's fairly unpredictable, but those periods of apnea are never as long as 20 seconds. Those periods when they're not breathing are never as long as 20 seconds. Otherwise, they would be having apneic events in their periodic breathing. Apnea is not normal. Periodic breathing, totally normal. I apologize once again for deep breathing into the microphone. The epidemiology of bruit. It's fairly rare. Happens in about 0.5 to 6% of all infants. It peaks between 1 and 3 months of age. The most common presentation is apnea, cyanosis, or difficulty breathing. And physical exam, by the time they get to a physician, it's often completely normal. The differential is pretty broad. About 50% of the time, it's idiopathic, meaning we have no idea what caused it. GERD is the most common diagnosed problem leading to an ALTI or a bruit. It can be silent until a bruit occurs, meaning the parents don't even realize that their infant has reflux. And then suddenly their infant goes floppy or becomes unresponsive, seems like they're not breathing well. The parents get very concerned that the infant is dying. And it turns out that they've had this underlying GERD that just hasn't been treated or managed yet. It could be a neurologic cause, like a seizure or something called a breath-holding spell, which are basically conscientious apneic events, where infants, especially hard-headed infants, when they're not getting their way, they will quite literally hold their breath until they pass out. Infections like pneumonia, pertussis, RSV, meningitis, anything that can really alter the respiratory drive and system. Cardiovascular causes like that prolonged QT that is leading to an arrhythmia or a dysrhythmia, congenital malformations or cardiomyopathy. And then there's a list, kind of an endless list of other possible differentials. Anemia, inborn areas of metabolism, other respiratory issues, non-accidental trauma, unfortunately has to be on any list when we're talking about a bruit. Apnea of prematurity or infancy, right? That should go away completely by the time the infant is 43 weeks post-conception. The history in a bruit. So what are the questions that we need to ask? What were the events leading up to the episode? So what was happening right beforehand? What was the infant doing? What were you doing? What positions were you in? Was the child awake and eating? Did their eyes roll back? Did their bodies stiffen or jerk? So trying to assess, did they have a seizure? What caused the event to stop? So we want to know, did parents actually initiate CPR? Did they do chest compressions? Did they do mouth-to-mouth? Have similar events occurred in the past? Has the kid been sick at all recently? Do they have any signs or symptoms of illness? Wheezing, cough, fever? Any siblings with a history of SIDS or bruit in the past? Any problems with pregnancy or the delivery? Did mom smoke while she was pregnant with the infant? Or is there any secondhand smoke exposure for the infant? And what position does the infant sleep in? So could there have possibly been some asphyxia that led up to this? There's no standard workup. It's really based on the findings of the history and physical exam. So it's important that we do a good history and physical exam. Reasonable initial studies include a CBC, looking for signs of infection or anemia, electrolytes, and glucose levels. And then you may also want to consider a lactate level, a chest x-ray, a urine analysis, an EKG, a urine tox screen if it's possible that the infant got into something or somebody fed the infant something, nasal swabs for different infections like RSV, pertussis, and so on and so forth. The management. It's important to consider admission for observation and investigation. And then while the infant is admitted, you want to place them on continuous cardiorespiratory monitoring so that we can see if they have another event in the hospital. We can actually see what's happening with their breathing. Do they actually become apneic? And what's happening with their heart, right? Is there an arrhythmia or a dysrhythmia? We treat them based on the results of their investigation. And then some people will send the kids home with those apnea monitors, but as we know, those apnea monitors aren't very helpful at all. Certainly does not prevent sudden infant death syndrome. You can imagine a bruit is very scary for the parents. They feel like their child almost died. And so they want almost every reassurance that we can give them that when they go home, their kid is still going to be safe. Risk factors for significant disease include a bruit that occurs over 2 months of age, any abnormal findings on physical examination, a lactate level that's greater than 2, which tells us there was probably some significant hypoxia, right? Remember reasons why we get lactic acidosis, why we get lactic acid buildup when we move into that anaerobic metabolism. And if a child has recurrent bruits, so they have more than just one of these episodes and it keeps happening, those are all risk factors. Those are all infants that we should work up even more aggressively and make sure we're monitoring them closely. All that I have for this part 1 of pediatric lung disease. I hope that you enjoyed it. If you have any questions or concerns, please don't hesitate to come and contact me. Thank you so much. Have a great day.